So just now we have another situation where we have a subluxated cataract. Now, so through these series of videos, we will try to judge which particular surgery you want to choose, SICS or phaco. And these are a couple of devices that I have just picturized. This is the CTR, which is being used for very commonly, and nowadays most of us like to use an injectable CTR. This is a single CONE with the eyelet on one side, and this is a double CONE with eyelet on two sides. This is a new entrant, not so new now. Lots of us are using it. It's a capsular tension segment, which is a small device, easy to put in, and this has to be usually combined with a CTR to for allowing the back to expand. And this, since we are not using, I'll just skip. So let's go to the videos now. So you can see this was a patient who had extensive subluxation almost from this cloaca to this cloaca. So it is almost about 4 to 5 cloacas of subluxation. So this patient had a history of trauma. Now I was in a dilemma whether it is the CTR would suffice or not, but unfortunately that day I did not have any other device. So maybe I would not have gone for a CTR alone, but this worked. And as soon as I put the CTR into the bag, the bag became central, and actually I have done a phaco in this case. So this is another case with the anterior capsular tear that you can see over here. Now the trick is that your rhexis has to be intact whenever you're putting these devices. So I did a rhexis a little away from the area of anterior capsular tear. The nucleus was this is an SIC is being done, so the nucleus was uh, delivered and through the anterior chamber maintainer, and after that I had created these partially dissected flaps, and this is the entry for fixing the single CONE. So this is a straight needle being passed through the partially pre-dissected tunnel, and it is brought out, and now the eyelid is fixed to the suture that is passed, and this is how you complete the surgery. So the message in this is that if you have an anterior capsular tear, you can create a rhexis away from the portion, and since the rhexis size is small, you should go for a foldable IOL in these cases, because while putting a PMA lens, the chances are that you may injure the remaining anterior capsule. This is another case with extensive subluxation. This was more than 180 subluxation. So I decided to go for an SICS, but then I think it got dissected. Anyway, I think let's leave that one. This is a patient, post-traumatic patient, where you can see there is an iridodialysis and there is a subluxation. So the first thing was to create a capsular rhexis, and the iris, the same iris hooks have been used to keep the iris away from the center. And after that, the rhexis was done. And this is a CTS being implanted. So this is a straight needle being docked into the 26 gauge needle, and this is being brought down. One has to be careful not to injure the posterior capsule when you are passing the straight needle, because here the PC is intact, and this is the CTS. It's a very small device, very easy to insert. Vis-a-vis what the amount of the bulkiness that you see in the CONE. So this is a small device, and you put it into the bag, and once you pull the suture, the CTS goes and sits into its correct position. And after that, in this patient, I have not used a CTR along with it, because I've decided to put a PMMA lens in this patient. But otherwise, if I put a CTS, I always put a CTR along with it to so that the bag is fully expanded. And this is the iridodialysis being repaired after that. So so this is another patient where we had the earlier series, which I had shown. We have already published this also. So we realized that if there is an extensive subluxation, let's say more than 5 or 6 hours, we found that it was easier to do phacoemulsification rather than doing an SICS, because if your nucleus is bulky and while you're trying to prolapse a nucleus out of the bag, you tend to injure the zonules more than when vis-a-vis when you break the nucleus within the bag. The only thing is that you have to be careful that you don't drop the entire bag nucleus complex into the vitreous, and for that you should use the hooks I had used for stabilizing the bag while the phacoemulsification was being done. So this is published, and if you want to see the results, this is another case where we had a bilateral lens coloboma. Again, we have published this, and in this, what we experienced was that the area where the coloboma was there were no zonules. So in the first case, I did an SICS, and let's see if the video.
Well, doctor, just a gentle reminder, it's 11:12 and we need to end the session by 11:25.
Okay. Just this video, I'll stop. I hope Dr. Sudhir joins by then. So this is, you can see the lens coloboma, and I have already prepared ports for the Sioni to be put in. And you see, the moment I finished my rexes and I tried to bring the nucleus out, despite my hydrodissection, the nucleus is not bulging from its place. So what is happening is it's like a keyhole. You put in your key into the lock and it gets stuck there. So this kidney shaped defect in the capsule doesn't allow the nucleus to prolapse out of the bag. So this is the problem that we encountered in this patient, and ultimately after struggling for multiple minutes, I decided to do an intracapsular, and this whole nucleus had to be brought out. So taking a cue from this particular case, in the second eye, I did a phacoemulsification, and we had a very good result. So basically the take home is that if you are choosing a patient of a lens, it's not a uveal coloboma I'm talking about, it's a lens coloboma, then you must directly go for a phacoemulsification, break the nucleus and then take it out. So I think that is it.